In general practice, understanding hepatobiliary biomarkers is crucial for diagnosing and managing various liver and gallbladder conditions. Biomarkers like ALT, AST, ALP, and bilirubin levels provide valuable insights into liver functions and biliary tract health. By monitoring these biomarkers, physicians can detect liver diseases early, assess severity, and track treatment progress. Incorporating hepatobiliary biomarkers into routine practice empowers clinicians to provide timely and targeted care, ultimately improving patient outcomes and quality of life. I request Dr.M.Suchitra M.D to present her views on the topic of hepatobiliary biomarkers in general practice. I request the chairperson, Dr. T. Saravanan sir, Professor and Head in Department of Biochemistry of Government Medical College and ESI Hospital, Coimbatore, to introduce the speaker and chair the session.
Good morning to one and all present here. First of all, I am congratulating Department of Biochemistry, Coimbatore Medical College, for conducting this grand CME. Covering all the topics. A very good experience. So we used to go to Tirupati. So everybody wants to go to Tirupati to worship Lord Venkateswara. But Madam Dr. Suchitra is all the way from Tirupati to worship us. Worship Coimbatore Medical College. Welcome, Madam. So hepatobiliary markers, liver function test. So what is the importance? Hepatobiliary markers in general practice. What is the importance of liver function test? If child bonds immediately, newborn, what test we are ordering? What test we are giving? Bilirubin. So bilirubin to assess the status of that infant to detect neonatal jaundice. So immediately after birth, we are doing liver function test bilirubin. And end-stage liver disease. End-stage liver disease with old age person with various liver disorders causing cirrhosis. The old age persons with end-stage liver disease, again we are ordering liver function test. So in between that various stages, various causes will cause liver damage and hepatobiliary markers are altered. So mainly our bilirubin liver enzymes, AST, ALT, alkaline phosphatase, gamma glutamate transferase, proteins. So normal proteins, total protein, albumin, globulin, everything will be altered in various diseases. So even we are taking paracetamol for treating fever. So by just taking paracetamol, that paracetamol itself will cause liver damage. The paracetamol itself will cause liver damage. The liver enzymes will be elevated. So that is the importance of doing hepatobiliary markers. So day-to-day practice, all inpatients, clinicians ordering liver function test to assess the liver function. So with these introductions, I welcome Dr. Suchitra Madam. Madam currently present working at Professor of Biochemistry, Venkateswara Institute of Medical Sciences at Tirupati. Madam has done MBBS at Siddhartha Medical College, Tumkur, and PG at Venkateswara Medical College, Tirupati. Madam has published almost 70 publications. This also editor to the book, various international books. Mainly, Madam has received the awards, Best Paper Award for clinical and scientific research. Fellowship award from also OMBI, Association of Medical Biochemistry of India. So with this introduction, the madam is going to present the topic.
Om Namo Venkateshaya. So I come from the holy city of Tirupati and I carry with me the blessings of Lord Venkateswara for the success of the CME program and to the HOD, Dr. Deepa Lakshmi Madam, for having invited me all the way here. I think it's a privilege to share the stage with so many honorable dignitaries and which Deepa Lakshmi Madam, your dean has praised so highly. I'm really proud to have been called by her. So now today my topic is on hepatobiliary markers. They said, please deal with it for creating interest and awareness among the students that biochemistry laboratory tests do have a lot of important role for the clinicians in treatment prognosis. So here today I'm going to talk about hepatobiliary markers. So what's the background of my study? So recent epidemiological data reveals that mortality due to chronic liver disease is increased globally. So that's the reason why we have to know about liver blood tests. The liver blood tests are checked very frequently to exclude liver disease for monitoring very potential effects of drugs. Suppose you're taking tuberculosis drug, as sir has already given a good starter. If you're taking some drugs, they ask you to do your LFT because liver is the main organ for detoxification. So that's why LFT is having an important role. And when a patient is unwell, they just write, do LFT, RFT, just a list. But you get abnormal results. That's the problem. How to deal with these abnormal results. And these abnormal liver blood tests are commonly encountered in primary care setting with mildly elevated transaminase levels being observed in 10 to 20% of the general population. When the significance is not clear, the patient appears fine. So what next? So liver disease. So why do we need to screen for abnormal liver blood test? Liver disease usually progresses silently for years or decades until the complications appear. So that's why the need is felt. Hence, irrespective of duration of presence of abnormal liver blood test or no clinical significance in the person who looks healthy, we try to evaluate for liver disease if needed. If needed. So coming to the topic. So this is for the MBBS students, undergraduates. We have to dwell into anatomy, physiology, and then biochemistry. So this is the hepatobiliary system. We all are familiar with it. The liver, right and left hepatic duct, cystic duct, common bile duct, gallbladder, which drains in the second part of the duodenum. So the bile is secreted into second part of duodenum. And any obstruction there leads to different types of jaundice because of liver failure due to obstruction, mechanical or medical conditions. So this is the hepatobiliary system, and liver is the largest organ in the abdomen and has important roles in hemostasis, metabolism. What metabolisms? Carbohydrate, lipid, and protein metabolism. It plays important role, especially in gluconeogenesis and storage of glycogen. It plays important role in protein synthesis. Almost all the proteins except immunoglobulins are synthesized by the liver and plays a role in bile secretion for excretion of cholesterol for enterohepatic circulation. And the importance of the hepatocytes are they proliferate. Any liver damage, they can proliferate and recover very fast. But if they are damaged, the proliferative capacity is lost. Functions of the liver mildly, production of bile, production of proteins, cholesterol production, storage of glucose as glycogen, conversion of ammonia, which is toxic, to urea, which is a non-toxic, non-protein, nitrogenous compound, storage of iron as ferritin, clearance of bilirubin, and production of bile. So these are the broad functions of the liver. And liver function test is also being called as liver blood test. So when you study UG, you say liver function test, but when you go into clinical side, they say liver blood test. So any terminology holds good. Reference ranges, these are not hard and fast rules. Some will change depending on the laboratory, depending on the type of kit being used. The reference ranges can change depending on the principle of the method. So generally, it's considered as less than 1 bilirubin, conjugated or direct bilirubin less than 0.3, total protein 6 to 8 grams, albumin 3.5 to 5, globulins 2.5, 2.0, 3.5. If you're not measuring globulins, you minus total proteins and albumin, you get globulins. AST less than 35, ALT less than 40 international units, ALP less than 90 or 90 to 120, and this has physiological limits. And abnormal LFT level is defined as a value exceeding the upper reference limit, but one should be aware. So not always an abnormal LFT is indicative of disease because there are different reference limits among the laboratories and differences based on age and gender. So can anyone tell me what is, I think most of the MBBS students have left after the break. So most of the time my talk comes after the break and crowd disappears. So anyway, I'm thankful to those who are here. So what are the things which can change with age and gender in this profile? Which do you think? What among these profile changes based on age and gender? Alkaline phosphatase, pregnancy, growing children, it is higher, and liver disease. So there's physiological basis and pathological basis, and not every abnormal test indicates the person is having a disease. So all these should be in the mind. Coming to the pathophysiology of the liver enzymes, a broad view about these enzymes, where they're located and how they are significant to the particular organ which we're discussing. Alanine transaminase. So you should know the reaction catalyzes. So biochemistry deals with the enzymes. And what are enzymes? Enzymes play a role in catalyzing the substrate to product. And they're located in particular tissues and organs, either in the cytoplasm or mitochondria. So depending on the locations, isoenzymes and organs, isoenzymes are changing. So what is this alanine transaminase? It is produced in the liver. Very good. We're interested in this. Very specific marker of hepatocellular injury. And low concentration are seen in other tissues. So it's more specific compared to aspartate transaminase. And throughout the day, you have fluctuations. And rise can occur with certain drugs or when you exercise. So ALT has some variations. Aspartate transaminase occurs in two isoenzymes forms, and mitochondrial isoenzyme is produced in the liver. So when ALT changes in necrosis, etc., AST also changes because one of it is produced in the liver. The cytosolic isoenzyme is present in skeletal muscle, heart, kidney tissues. Therefore, it is not that specific for liver compared to ALT. And caution must be exercised when you evaluate hepatocellular damage. And it rises along with ALT. So ALT, AST, both will increase in liver disease, but ALT is more specific for liver disease compared to AST because of the location availability. The next enzyme pattern is ALP, alkaline phosphatase. It's a group of isoenzymes, as I told you. They are produced from pregnant women, placenta, growing bone, liver, kidney, pancreas. So group of isoenzymes that act to dephosphorylate. So alkaline phosphatase. So they play a role to dephosphorylate a group of molecules. And they're produced by the cells lining the bile ducts and canaliculi. And they release in response to accumulation of bile. Whenever there's irritation to the bile duct, common bile duct, bile juice is excreted. Whenever there's stasis, the ALP is secreted high. Therefore, obstructive jaundice. The obstruction outflow, ALP can increase. So that's a specialty of alkaline phosphatase. And non-hepatic, other than liver, it is produced by the kidney, intestine. That's why I said it has got isoenzymes, 5 isoenzymes, leukocytes, placenta, and bone. Pregnancy also increase, children it can increase. Pathological, Paget's disease, renal disease, and bone metastasis. Secondaries, prostate cancer, secondaries in the bone, ALP can increase. So there is differences in ALP rise. Gamma glutamyl transferase, present in the liver, kidney, pancreas, and intestine. So there is no bone. And ALP and GGT go in parallel. And ALP in bone. So GGT can say, no, it's from the liver. So in that way, GGT scores more over ALP because of its location. When the bone is involved, GGT is more considered compared to ALP. So present in liver, kidney, pancreas, it is found in the microsomes, hepatocytes, and biliary epithelial cells. And the GGT elevation along with ALP is highly suggestive of liver and biliary tract disease because of cholestasis. Subject to rise in hepatic enzyme induction, drug use, such as rifampicin and phenytoin. So a lot of drug usage causes liver enzymes to increase. Coming to what are the tests? So you have these four enzymes. Basically, when you say hepatobiliary disease, the enzymes, liver enzymes, we'll talk about bilirubin later on. So this, when you talk about hepatocellular injury, what are they? Among these enzymes which denote injury to the liver cells. Elevated seated transaminases seen in hepatocellular injury. So there is injury to the cells caused by viral agents. In acute stage of viral hepatitis, a rapid rise in ALT occurs even before bilirubin is rising. So before bilirubin, ALT can increase. And ALT levels greater than AST levels are always seen in chronic viral hepatitis and NAFLD. What is NAFLD? Non-alcoholic fatty liver disease, not because of alcohol. So liver disease, different types are there. That is a different big topic, cannot be dealt now. The source of ALT is from the liver cells damaged because of the virus. Hepatitis A virus, so you see the beauty of the disease. Hepatitis A virus especially is present in the blood, viremia, feces of the person up to 2 weeks before the illness develops. So in case of hepatitis, the virus is there first, the blood, saying I'm there. Blood and feces. After that, ALT rises. After the bilirubin rises. So the series of testing, what you want to test. Early phase, what do you see? You go to virology department. You want to see among the liver enzymes, you see there's no bilirubin, don't worry. ALT will be there. So these chronological order of the rise indicates which stage the patient is and which test you have to select. So if you know the etiology of the disease, you know which test to select, when to select, and why it's important. Types of cholestatic liver injury, we all know. Extrahepatic cholestasis, intrahepatic. So the obstruction to the outflow of bile. When the obstruction outflow of bile, what happens? Bile goes back into the liver, regurgitation. Liver cells gets damaged. Bile goes to the blood. Now bile, it's going back. The contents going to the blood. So there is extrahepatic mechanical obstruction to the bile. So you have mechanical and medical. So mechanical obstruction to the bile outflow. So when you go for an ultrasound, you see biliary dilatation. So we have no single test is indicative of a disease. We have to go with multiple laboratories and multiple diagnostic modalities to arrive at a conclusion. So in this condition, you have an ultrasound, you can see a dilatation, and causes of this type of mechanical obstruction is obstruction of the biliary tract due to malignancy or gallstones. So some obstruction to outflow, wherever, whatever surrounding the bile duct, common bile duct, any growth or any stones in that compresses the bile duct and obstructs the outflow of bile, and the bile goes back. So that is the mechanical obstruction. When you see intrahepatic cholestasis, cholestasis means staying back of the bile, impairments of bile formation by the hepatocytes, not able to form. Normal biliary system on abdominal, it is, when you do ultrasound, the biliary system is normal. So that's the difference. You can see dilatation here. Here you see ultrasound normal. Only thing you can see the jaundice features. Causes of this impaired intrahepatic cholestasis is viral hepatitis due to alcohol consumption, drug-induced, drugs can be hepatotoxic, chronic liver disease, and genetic defects. So these can lead to intrahepatic cholestasis. Now coming to tests of cholestatic liver injury, ALP and gamma GT. Now we saw what are the types of liver cholestasis is there. Now what are the tests to understand these stasis? So ALP and GGT, elevation of GGT is usually seen together with elevated ALP in cholestatic liver disease. So both of them go together. They correlate well with each other and can be used for distinction between liver and bone because ALP is also bone. So we don't know. Small child, you don't know. Is it because of the growing child or because of he's having some jaundice? So their GGT will be useful. Isolated elevation of the serum GGT level. If only GGT is elevated, he's taken alcohol. Check alcohol consumption, non-alcoholic fatty liver disease, a case of obesity, you can see only GGT level increase, drug-induced liver injury. GGT may be a strong predictor, biomarker of cellular antioxidant inadequacy, risk of metabolic syndrome, diabetes, cardiovascular disease, and all-cause mortality. Because liver is the organ, all metabolic processes, and whatever starts outside impinges on the liver, or the liver is the causative agent. So liver is at the end of any insult. Any insult happens from the liver. Coming to the other tests. So sir has already told earlier, some drugs we take, we have to go for LFT. So that is indicating injury. So drug-induced cholestasis presents with a rise in ALP. So only ALP is rising, no GGT. GTT only rises alcohol consumption. So ALP is rising compared to GGT because of drug-induced cholestasis, or with ALP and ALT and ALP ratio of less than 2. The drugs will be antibiotics, immunosuppressants, tricyclic antidepressants, angiotensin converting enzyme inhibitors. So any treatment given for a pathology or some other disease can impinge on the liver, can be a cause of jaundice. Which type of jaundice? You have to demarcate because of, so the primary insult is not the liver. The primary insult is another agent causing liver injury. So you should know the sequence of events. Is this a primary event or secondary event? Because the treatment vary. If you want to treat, you should know where is the source of the insult. So that is about drug-induced. There's one term I came across in one article written by clinician, massive transaminitis, what to consider. So I thought, okay, I'll share with you. Liver transaminases are often only mildly increased in alcoholic liver disease, rising to no higher than 6 or 7 times. So you should see the magnitude of rise, 6 or 7 times. In 98% of cases, absolute AST and ALT levels more than 500 are virtually not due to alcohol. So when you see the levels, it's more than 500, you do not consider the alcoholic. Some other reason is there. So that is massive transaminitis. In acute setting, the most likely causes for this rise of more than 500 units per liter for massive transaminitis are paracetamol overdose. What sir has already correctly told, taking drugs, they say don't take paracetamol. They affect the kidney, they affect the liver also. So we think you have renal damage, you have even liver because of toxic injury to the hepatocytes. So paracetamol overdosage, the most common cause of acute liver failure, Western society. In our country, it is tuberculosis treatment. Anti-tuberculosis drugs. You go for liver tests every month. I am a case of spinal tuberculosis. I suffered. I have a rod in my back also. I used to have tuberculosis treatment, and I used to go every month to the testing for LFT to see whether any change. So that time I was not that into LFT and all, but now I understood the importance of me going for the testing for LFT. And luckily nothing was there, but may happen. So treatment anti-tuberculosis drugs, hypoxic liver injury, where there's no oxygen, and acute viral hepatitis. So these can lead to massive transaminitis. Now coming to enzyme ratios. Now always medicine does not stop with the absolute values of the markers. We try to see what is the relationship between them as a ratio. Okay, one of the ratios are enzyme ratios to predict disease severity, prognosis, and management. So in addition to the magnitude of transaminase elevations, there is a ratio called as de Ritis ratio, ratio of AST to ALT, which can be useful in determining the etiology of elevated transmission. So is it ALT rise or AST rise? How to know? See the ratio. So ratio will tell you. And the elevated AST-ALT ratio is predictive of long-term complications, including fibrosis, which is the end stage. So end stage of any liver disease is fibrosis, cirrhosis, malignancy. What malignancy? Hepatocellular carcinoma in the long run. So it is including fibrosis, cirrhosis in chronic viral hepatitis, alcoholism, or NAFLD. So ratio is elevated, remains elevated long time, it's not good. It indicates he's going for complications. Any transaminases should come down with treatment. It's not coming down. It indicates a worse prognosis. So let us see a summary. I didn't want to talk about every disease. So this slide will just summarize the enzyme pattern and the ratios in the disease. So cholestasis, you can see ALP is double rise. So we can see ALP is elevated in cholestasis. AST is just elevated. Gamma GT is similar to ALP. The ratio less than 1.5. Primary biliary cirrhosis, ALP is double, triple. AST can be normal, ALT can be normal, GGT still lower than AST, ALT cirrhosis. Okay, so you are using ALP increase, they may be normal. AST, ALT ratio more than 1 may indicate cirrhosis, and more than 1.12 indicates esophageal varices. So next complication is going on as the ratio increases. So the ratios are very significant. As long as you're seeing only AST, LT, you don't know what's happening. When you see the ratio, you know, you have some idea of what's happening. So alcoholic liver disease, ALP is normal, fine, just raised or normal. These are all just normal. GGT is raised. So that is why you can see the arrows and where they take a, where they stand first in the particular disease sequence. GGT is always double arrow. So here, AST-ALT ratio more than 2. When you see non-alcoholic fatty liver disease, ALP is normal or elevated. All these can be just elevated. And the ratio less than 1 indicates cirrhosis is present, less than 1. Okay. Wilson's disease, ALP just not raised, just raised. These two are raised. Liver enzymes are raised. And the ratio is more than 2.2 or bilirubin. ALP and bilirubin ratio they're considering here less than 4 or AST-ALT ratio more than 2.2. So the ratios are playing an emerging role in diagnosing of disease other than only the enzyme patterns. So similarly with hepatitis B, autoimmune hepatitis, ischemic liver injury, toxic injury to liver, you can see depending on the arrows, the significance of enzymes and how the ratios behave in the particular cases. So this is the enzyme pattern and the importance of the AST-ALT ratio in disease. Now, a famous, when you say jaundice, we all think of bilirubin. So why we started the enzymes is, before bilirubin rises, enzymes can rise or rise before bilirubin. Only when bilirubin goes more than 2 milligrams, you call it as jaundice and you can see it as visually as icterus. But because we are dark skinned people, we cannot see that. In fair skin, you can see the icteric on the skin, deposition in the skin. So lifespan RBC is this general for undergraduates, about 120 days. As it goes to the endocrine system, the membrane ruptures, contents are released, hemoglobin is broken down, heme phagocytized macrophages, globin, amino acids, heme is oxidized to biliverdin, and then biliverdin reduced to bilirubin. About 4 milligrams per kg per day is produced. Unconjugated water insoluble form, and bilirubin, about 20% is coming from other sources such as ineffective erythropoiesis, immature RBCs breakdown frequently, and other heme proteins like muscle myoglobin and cytochromes can contribute to bilirubin 20% normally. The remaining 80% is from hemoglobin degradation. That is the source of bilirubin. And because it is unconjugated, so as in the morning lecture also I heard, albumin. Albumin transports many of the hormones, cortisol binding protein. So it is a transport. Albumin main function is transporting many molecules because most of the molecules are not soluble in water. So this albumin transports like a ship, it carries. So bilirubin is also transported in the liver, bound to albumin. After going to the liver, the albumin goes away and there's some transport proteins which take bilirubin inside and cause conjugation with the enzymes to give bilirubin diglucuronide, which is then excreted in the bile. Okay, so that is the story of hemoglobin and the entry of bilirubin and the story of bilirubin conjugation and excretion in the bile after a particular process. So types of jaundice. So when you're interested in hepatobiliary system, you should know what are the types of jaundice. So we all know overview, prehepatic, hepatic, posthepatic. So prehepatic can be unconjugated hyperbilirubinemia because of overproduction of bilirubin, which is not, liver is not able to conjugate. In case of malaria, there is hemolysis. Any cause of hemolysis can cause increased bilirubin, which remains unconjugated because the liver is saturated. It says, no, I cannot conjugate. So it remains unconjugated. So that is, or impaired uptake by the liver. So production is there, but it's not uptaken by the liver. So unconjugated is more in concentration. When you see hepatic, decreased conjugation because hepatic cell damage. So more of unconjugated bilirubin, biphasic response. It can be a biphasic response. We'll see what is the biphasic response. When there is an obstruction to the outflow of bile because of malignancy, gallbladders, okay? Post-hepatic jaundice, decreased excretion of bile in the biliary tract into the duodenum because of either intrahepatic or extrahepatic obstruction. Here, the liver is fine. The liver is conjugating. Whatever bilirubin is coming is normal. The liver is conjugating. Problem is, what is conjugate is not being sent out. So therefore, conjugated hyperbilirubemia is seen. So these are the types of bilirubins which are seen depending on the etiology of jaundice. So prehepatic, When your reticuloendothelial system, hemoglobin, heme overproduction, dyserythropoiesis, ineffective erythropoiesis is the clinical condition. Physiological hemolysis can be there. When it comes to the blood, heme overproduction, there is more of unconjugated bilirubin. And sometimes drug treatment, what happens? The drugs will compete for albumin. One of the problems is whenever you take drugs compete for albumin binding because albumin is the main transport protein for drugs, free fatty acids, for bilirubin, everything it transports. So when albumin is not there, what happens? Drugs are taking it up, bilirubin is left free. So therefore it leads as though it is increased. Okay, so drug competition for albumin binding. So bilirubin does not have albumin for binding. So more of unconjugated bilirubin is there in the circulation because of drugs. And because of low plasma albumin, unconjugated bilirubin can be increased. Transport protein, which is going to uptake the bilirubin into the liver, when drug competition like rifampicin or neonatal deficiency of the transport protein for the uptake of the bilirubin, after albumin is released, bilirubin should be taken up into the liver. If the transport protein is not there, there can be lead to increased unconjugated bilirubin. In hepatic, conjugation itself is decreased. So neonatal enzyme deficiency, Gilbert syndrome, Crigler-Najjar syndrome, or because of drug inhibition, post-hepatic active transport excretion defect, cholestasis because of drugs, and syndrome change, Dubin-Johnson syndrome, Rota syndrome. So these you've been studying sequentially from first MBBS, also in your post-graduation. The same table holds good. So the types of jaundice and the types of syndromes will vary because of the reason is different. The reasons are different. So you should consider the reasons because the treatment depends on the reason. What you see can be the same picture, but what is giving us the picture can be 1, 2, 3. If you don't know it's 1, 2, or 3, what are you going to treat? So you should know what are the 3 reasons and you should come to the point which is the reason. That reason is only has to be addressed. Otherwise, the disorder remains the same. Okay, so multiple reasons you should know. So isolated bilirubin increase, most commonly caused by Gilbert syndrome, about 5 to 8% of the population. So I always say it's very rare. But I always tell the students, maybe you're the doctor who's going to see the rare case. You may be the one seeing that 1%. You may be the one seeing that 10%. So don't just leave it, learn it. Because you don't know. You may be the one coming in the paper, newspaper clipping saying that you detected that. Okay, so you have to load your information in your CNS brain. So this Gilbert syndrome is common. You consider hemolysis and also you consider hemolysis in a patient with anemia. If patient is anemic, you consider hemolysis. Maybe there's some hemolysis. This needs to be excluded. So you go for other pathology testing, reticulocyte count. You can do a LDH in your lab. You can do haptoglobulin to see whether it's because hemolysis or not because of hemolysis. So whenever you see anemic patient, rule out hemolysis by asking for other investigations, LDH. If the unconjugated bilirubin is more markedly elevated, then rarer cases such as Crigler-Najjar syndrome should be considered and genetic testing should be undertaken. So depending on the picture, the patient clinical picture, but unfortunately for biochemistry, because you're in the laboratory, you cannot see the clinical picture. So only you have to interact with your colleagues in the medicine or gastroenterology, you interact with them, get to know the history. Anyway, you won't play a role in the treatment, but you should know because you can guide further testing. Sir, you can do LDH, sir. You want to rule out? Come, we'll do LDH. So you can suggest being in the laboratory to suggest investigation because they are into the patient, responding to patient, attenders, and running around. So what happens? Maybe they may miss. So you are here more focused and in the laboratory to suggest, please go for this to rule out kindly. So even responsibility is there in the laboratory to share the information with the clinicians. So this we all know, bilirubin measurement. Whenever bilirubin is more than 2 milligrams per DL, you call jaundice or icterus. Vandenberg's reaction. So you have a direct fraction when you add sulfonilic acid. For 1 minute, you get a color measured, direct. But if it's indirect means unconjugated. Direct means conjugate bilirubin. Indirect means unconjugate bilirubin. Which fraction is more? So you add alcohol, that is the accelerator or methanol, and sulfonilic acid. The color deepens, and you measure, that is the total bilirubin. Total bilirubin minus the direct bilirubin gives the indirect fraction. So it's a calculated. Indirect is a calculated. Color deepens, it is called as biphasic. When the color develops, when you add the methanol, the color becomes more deeper, it's called as biphasic. So both are there, direct and indirect bilirubins are elevated. So depend, and then you can see the picture. So this is our most favorite picture. For LFT means you put this table. Okay. So I think this table makes you feel at home. So I thought I'll put this table so we're not getting carried away with all the ratios, numbers 1.2, 1.5. This picture looks nice. Types of bilirubin elevated, you all know, prehepatic, hepatic, posthepatic. Prehepatic unconjugated because hemolysis, etc. More bilirubin production. Hepatic, it can be biphasic. Posthepatic, mostly conjugated. Vandenberg test, indirect positive, biphasic or direct positive. Urine, you can see bilirubin, urobilinogen, bile salts. Depending on the picture, bilirubin can be absent. Depending on the pathophysiology, conjugate bilirubin is present in the urine. Post-hepatic, more because it's not going in the stools. Where is it going? It's going to the blood, getting cleared by the kidneys. So whole blood system is circulating in the kidneys, clearance. So whenever it's biliary tract, it does not go to GI system. Next mode is stercobilinogen. That is giving the color to the stools. The brown color is because of stercobilins. When there's obstruction, that bilirubin form is not going there, undergoing deconjugation and all that. So therefore, the stools are clay colored. So where is it going? It's going to the kidneys, getting cleared, excrete urine. Urine becomes high colored. High colored urine, stools are clay colored because it's obstructed. So urine color, stool color changes depending on the pathophysiology. So dark brown color in prehepatic, normal or decreased color in hepatic, clay color stools in the posthepatic. AST, ALT are normal, very high in hepatic. So AST, ALT very high means mostly hepatic. They can be normal or they can be increased here. Here, very high. ALP levels normal, obstructive, 10 to 12 times increase, 2 to 3 times increase. So the ALP levels also indicate what is the type of jaundice. So because the levels are numbers, we went for ratios. Because the levels are just numbers, we went for what are the ratios. Okay. So this is the basic picture of jaundice. Coming to synthetic functions. What do you think are the synthetic functions of liver? I already told you, sir also told. What are synthetic functions? No MBBS students? MBBS students, sir? Yeah. Last week only. So what are the tests for synthetic functions? All are after coffee, snacks, all are sleeping? Yes, it's common. Any volunteers? No. Madam is okay. I'll continue because other speakers are there. Albumin. So albumin is one of the commonest protein which is synthesized by the liver. Liver synthesizes almost all the serum proteins like albumin, prothrombin, ceruloplasmin, alpha-1 antitrypsin, haptoglobulin, transferrin. So all these except immunoglobulins. Immunoglobulin synthesized by plasma cells. So albumin reflects the liver mass, functioning liver mass. It has a very long half-life, about 20 days. Therefore, it's not a good indicator of acute. Any acute liver disease, it's not albumin. It's chronic. Okay. And normal albumin globulin ratio. Here, one more ratio you have. Not only enzyme ratios, AG ratio. 1.5 to 2.5 is to 1 is the normal ratio. Low ratio indicates liver cirrhosis. Albumin is also acute negative phase protein. You know what is acute phase protein? Whenever there's acute inflammation, the protein changes. Acute phase protein. How does it change? Negative decreases. Positive acute CRP increases. So you call them acute phase. When there's inflammation, they change. Acute positive, there's increase. Acute negative, there is a decrease. So albumin is acute negative phase protein, it decreases. CRP is acute phase positive protein, inflammatory marker, CRP. Okay. So it's a marker of inflammation with low levels found in acute infection, sepsis, inflammatory disorders, heart failure, malnutrition, malabsorption, renal failure, because it's lost in the urine. So it does not indicate liver. Nephrotic syndrome does not indicate liver. Protein losing enteropathy. So all these conditions, albumin changes. So it's not that good indicator of liver if there's a kidney problem also. So we have to select our tests, but it's broadly speaks about liver function tests. Stop moving. No? Changed? Yeah. Sorry. Go back. Okay. Prothrombin. So prothrombin is one more protein produced by the liver. Okay. So prothrombin, what it does, converts prothrombin to thrombin. So this thrombin converts fibrinogen to fibrin, and fibrin, along with platelets, it forms a mesh fibrin clot. So a lot of clotting factors assist this prothrombin by calcium, platelets, factor 10A, 5A, phospholipids, calcium, the conversion of prothrombin to thrombin, and which helps in with calcium fibrinogen. So calcium is factor 4. So this clotting mechanism is stimulated with the help of liver because liver produces prothrombin. But we are not doing prothrombin, I don't know. In our place, prothrombin time is done by pathology. But we should have awareness because prothrombin is produced. One of the liver function test is prothrombin. And prothrombin time is done by another laboratory. Does not mean you close your eyes. You should know about it, isn't it? You should talk with your colleagues across the labs and across the branches. Okay. So this is the clotting mechanism where thrombin plays an important role. Prothrombin time is the clotting factor synthesized by the liver. It measures the time taken for a clot to form in the blood sample. And coagulation cascade. What is the cascade? It is the extrinsic and common pathways linking together in the coagulation, which would detect deficiencies of clotting factors 2, 5, 7, 10, low fibrinogen, which is again produced in the liver. Vitamin K is required for activation of prothrombin. So vitamin K deficiency, what is vitamin K? Fat soluble vitamin, ADEK, fat soluble. Whenever absorption problem is there, vitamin K deficiency can exist. Because of vitamin K deficiency, you can have bleeding disorders. So vitamin K deficiency, you should rule out before saying it is because of liver. So a lot of other factors are impinging and overlapping onto the actual functionality. So vitamin K is required for activation. Vitamin K deficiency because of any extrahepatic disorders, malabsorption, hematological disorders, prolonged prothrombin time. Therefore, you supplement vitamin K parenterally and do the test before and after. This we will not do. We'll see just the PT in the pathology lab in our center. Liver disease, prothrombin time is prolonged. Reference range is about 9 to 13 seconds or up to 20 seconds also. The values change depending on the laboratory. It's not specific indicator of liver function, but it is useful, but not specific because it has many other things which has to be ruled out before you say it's because of liver. So that those things will hinder liver function. So something is called as INR. So I put this slide because I wanted to understand first. So I thought, okay, let me share this with you. INR, because in pathology, I don't see it also. I say, INR is pathology and my husband is pathology. I call him, you see what that INR is. So I thought, no, we should also know what it is. So the INR is international normalized ratio in the patient's prothrombin time divided by the normal reference range to the power of ISI, International Sensitivity Index 1.3 to 1.5. So many of the laboratories report as INR, which is equal to prothrombin time. So INR or prothrombin time is indicative of bleeding clotting problems, which is related to liver pathology, may or may not be sensitive to liver pathology. Other laboratory abnormalities in chronic liver disease, platelet count. Again, platelet, not ours, but we should know. Platelets done by pathology as a part of the blood profile, complete blood picture. Thrombocytopenia, common chronic liver disease, maybe an early marker of chronic liver disease and portal hypertension. Because why you have low platelets? Two ways. Production is less or breakage is more. It's low production or it's produced normally, but it's getting broken or deleted faster, more degradation. Okay. One is production, next is clearance. So one is reining back means either its production is more or its clearance is not there. So somewhere entry and exit should be checked. What is the problem because of the entry? Any problem due to exit. So that's why it's increased or decreasing in the circulation. Only two reasons, production or clearance. So here, decreased production due to bone marrow suppression caused by again toxins such as alcohol, drugs, iron overload. I think with this today's CME, people will take wow, I will not drink because I'm going to damage my liver. So many problems, complications are there. Okay. Because of alcohol, drugs or iron overload. So that's why they say don't take drugs over the counter without the prescription, the common man, because he's inducing some damage to his body by all this. Or sequestration of platelets in the spleen, or because of destruction of spleen, because of portal hypertension, okay, because of liver fibrosis, the platelets are getting damaged. And destruction of platelets is seen in liver cirrhosis because of shear stress. What do you mean by shear stress? When it's flowing in the blood, when they rub against each other, or when it's going through the pathways, shear stress, something causing stress on the platelets. Okay. Shear stress, okay, fibrinolysis, and autoimmune liver disorders because immunologically mediated destruction of platelets, antigen antibody reaction. They recognize the platelets as foreign and kill it. Okay, so therefore destruction of platelets occurs more. So other laboratory abnormalities in chronic liver disease, LDH. So I spoke about LDH earlier. Once again, let's see what's the LDH. It's typically elevated in liver disease. It's associated with hemolysis, solid tumors, any malignancy, lymphomas, viral hepatitis, or during ischemic injury. Therefore, LDH is not specific to the liver, as the enzyme is present in liver, heart, muscles, and insult to any of these organs cause increase in LDH. So LDH also has got isoenzymes like ALP. So therefore, wherever the source is, but it is increased even in liver disorders, LDH. So that also can signifies. So coming to the final path, algorithm for diagnosing liver disease. Though I am the laboratory, I'm not practicing. At least we should know what is the importance of a test, how it's going to lead the clinician forward. Okay. Abnormal liver enzyme profile, when ALT or AST is raised 3 times more than normal value, ALP less than 2 times, you think it's hepatocellular disease. When ALT or AST is about just less than 3 times, ALP is more than 2 times. See the combination, cholestatic disease. You come to a broad categorization. Then you check for albumin maybe. Albumin is normal, hepatitis. Albumin is low, chronic. So albumin is not indicator of acute phase. Albumin is a chronic indicator. So if it's normal, it is acute hepatitis because you're seeing the enzyme change. If it's low, yeah, it's chronic hepatitis. Along with the enzymes, it's changing. And cholestasis, again, albumin is normal, acute, low, it's chronic cholestasis. In acute cholestasis, high GGT along with ALP. When ALP is increased, what do you see parallelly with ALP? GGT. So because ALP can also come from the bone, so we don't know. So go for GGT, high GGT, intrahepatic cholestasis, mild increased GGT, extrahepatic cholestasis. So the increase of the GGT, mild or high, 1 arrow or 2 arrows indicates the pathology has changed. Coming to the this conclusion slide, how do you treat the like in the laboratory, we're giving the values. So this slide was eye-opener for me also. We just give the value saying, my QC is fine, my instrument is working fine, my water quality is fine, I am fine, my technicians are fine, no fighting, everything is fine. I can validate it. But with that value, what's happening to the patient care is more interesting and more thought-provoking because with this value, they're going to go forward or go back again. So this slide make me think that laboratory plays very important part in treatment of patient care, prognosis and management. So when you see, let us see the color coding. Yellow box, it's the initial evaluation of the clinical presentation. So let's see what are the yellow boxes here. You take a first history. We don't take it. Alcohol, metabolic syndrome, what is BMI, any drugs he has taken, what are risk factors for viral hepatitis, he has food outside, consumed some contaminated water, etc. Personal history, okay, comorbidities, has he traveled outside, he went somewhere, had food outside. So all the things you take history and then clinical pattern recognition. So we told yellow boxes are initial evaluation. So you evaluate. What do you evaluate? All these yellow boxes are biochemistry. Hepatic liver enzymes, ALT, AST. Then you see jaundice, low albumin, prolonged INR, isolated bilirubin raise, isolated colon ALP is increased, GGT is there, or search for alcohol-related liver disorder algorithm. So biochemistry comes into the particular evaluation of a clinical presentation for a suspected case of jaundice, suspected case. Next, we'll go on to the red box. What is the red box? Urgent referral to secondary care. We cannot do in primary, we go to secondary care. Synthetic failure, jaundice, low albumin, suspected malignancy, there's weight loss, cholestasis, we go for referral to the subspecialty. It can be hepatocellular cancer. When you go for hepatocellular cancer, again, biochemistry is there. You know in which form biochemistry is there? A marker for hepatocellular cancer. Biochemistry is doing it. Which one? Loudly. See, your teachers are telling. Alpha fetoprotein, AFP. So AFP is a marker of hepatocellular carcinoma. But because madam said talk about general practice, I stopped with that. We go on, it is secondary care. So secondary care, biochemistry is there in the form of AFP, tumor marker, which says there is cancer. About 500 units increase indicates hepatocellular cancer. So the levels also change. So that is urgent secondary care. Now let us see gray box. What is the gray box? All the tests that should be requested at that stage. So if you see ALT increase, AST increase, they go for ultrasound. After seeing the liver enzymes, they go for next investigation. What is that? Ultrasound. You go for hepatitis B or C. So after seeing your bilirubin and ALP, AST, then they're going for ultrasound. Then they're going for viral scan, hepatitis virus. Okay. So you go for hepatitis B, C, autoantibodies, ferritin transfer. Again, biochemistry is there. HbA1c is diabetic, NAFLD or not. They go to check. What do you see here? Only bilirubin is raised, most commonly due to Gilbert syndrome, and less commonly to hemolysis. Consider reticulocyte count, LDH, haptoglobulin. So next line of disorder again is biochemistry. When you say ALP or GGT increased, you go for GGT, ultrasound, and liver etiology screening, autoantibodies, ferritin transfer. So the tests will follow depending on the yellow box. The gray boxes follow. The gray box, you may be there, you may not be there. So biochemistry can be there, or another diagnostic modality can be there in the gray box. So finally, what is the orange box? Areas of diagnostic uncertainty. Orange. Still we don't know. AST, ALT remain abnormal. ALP, GGT remain abnormal. So we don't know why they're abnormal. Uncertainty is there. It looks fine, but there's some problem. Ultrasound is fine. Everything is fine, but there's some problem. Okay. Green boxes, final definitive outcome for users of the pathway. So we come to conclusion, is NAFLD, there's dyslipidemia, hypertension, treated. Refer for further evaluation. Gilbert syndrome, go for genetic testing. Refer to specialist. So conclusion is given by the green box by the primary investigations, secondary, still not definitive, or secondary treatment, and final treat. So many layers are there for addressing a case of jaundice or a case of hepatobiliary system disorders. So this algorithm shows the importance. What do you do with the liver blood test? What do they convey? Hepatobiliary enzymes, when interpreted in isolation, what do they say? Only the enzymes. What do they speak? They say some injury is ongoing. Only AST, ALT is increasing. Some ongoing liver injury is going on. Bilirubin, albumin, PT, what do they say? They say liver function. Is the liver functioning normally? Synthetic function. And platelets, what do they say? The fibrosis. Platelets come in last. So when platelets are decreased or increased, they convey about fibrosis. Means the next level of damage has started, and fibrosis can lead to cirrhosis. Cirrhosis can lead to hepatocellular carcinoma. Take home message. Knowledge of how to correctly analyze the liver enzymes is essential in the diagnosis, monitoring, and treatment of liver disease. Okay. Although a variety of laboratory imaging investigations are available to help and enhance knowledge of liver enzyme patterns, the liver enzyme ratios can help prevent unnecessary investigation. Okay. With one step only can conclude. So you don't have to go further. And or they can suggest interventions such as liver biopsy. In case of NAFLD, you produce the liver biopsy and check any further pathology is there. So either you can stop or you can direct them to go further. That is the importance of liver enzymes in the system. So these are my references, very few. Thank you. Once again, the blessings of Lord Balaji. I pray for all of us. Thank you.
It's a wonderful talk given by Madam. So Madam almost elaborated all the points in liver function test. So liver function test is an important university question for you. So most of the times they will ask in the university liver function test for UG as well as PG. Medicine also it is very important. Madam almost elaborated all the points. The excretory function, bilirubin, different type of jaundice. How can we differentiate different type of pre-hepatic, hepatic, and post-hepatic jaundice, and synthetic functions, and the various things in the liver? So we'll give good applause to the madam. So any questions? Sir, okay, I will ask question. You know hepatitis. What are the causes for hepatitis? So hepatitis, common cause, viral hepatitis, alcoholic hepatitis. What is ischemic hepatitis? So with this we conclude. What is ischemic hepatitis? So ischemic hepatitis is a hypoperfusion to the liver. So lack of blood supply to the liver due to some cause, some cardiogenic shock or septic shock. So blood flow to the liver cells are impaired. So some 10 to 15% of the cases with cardiogenic shock or septic shock, they develop ischemic hepatitis. So if you do the liver enzymes, so levels will be enormously elevated like more than 10,000. Your AST, ALT level will be more than 10,000. So it is some research point. You can academic interest. I am telling. So you can check with any stage liver disorder, cardiogenic shock or septic shock. The liver enzymes will be and prognosis will be very poor in that cases. So with that, we will conclude the session. Thank you.
Thank you, sir. Thank you, ma'am. That was genuinely illuminating. Now I call upon the chairperson, Dr. T. Saravanan, sir, to felicitate the speaker. Now I call upon his respected HOD, Dr. M.D. ma'am, to felicitate the chairperson.